They go to the health outpost, no X-ray. Try to go to another hospital. The knowledge, skills, and attitude of people's child are available. They make it to the road, and eventually make it to an area, a hospital, that has the skills, hopefully, to take care of the injury. If the child is lucky, next to peaceful, with disabilities, and also people. Unlucky, he or she may end up conditioning the same. They may end up with patients, my argument, and I think the argument that a lot of people that are working recently to take care of their own problems, read the quote, can you imagine take balls out of the tree, goes to a hospital, or goes to a healthcare house, and they do not have the expertise to treat them. We've gone a long way in the last few years to make an impact in preventing this. Over the course of the next 20 minutes, I'm going to touch on 4 themes. We can see that I'm working right now on my 9th professional life, so my past. Probably, hopefully, this is my last one, and my last week is at the beginning of lifetime. That's my team, and that's us. We're actually about 35 Sub-Saharan Africa. The main alliance said in the letter, we want to compete in something compared to national. We're not reading with the we're collaborating with ESOT, and you can't do it alone. Our budget is about $8 million US a year, but I have more money than be able to spend. The 4 areas I'm going to touch upon over the next 20 minutes is I want to talk about injuries. Everyone talks about malaria, TB, HIV, AIDS, but no one talks about injuries except you. And I also want to talk about the trends in trauma and orthopedics in LMICs. I want to show all the good work that's been done in this country, not just over the last 10 years, but over the last 20 years. And last but not least, I want to go over some of the lessons that I've learned, the humility that I've learned over the last 10 years, because up until January 2015, I had never been in Africa. I had 0 African experience. Now I can say that I've learned a few things. So far, so good? I'm not speaking too quickly? Clear? Good. How many of you drove to the venue this morning? How many of you drove? Raise your hand. You're all staying at the hotel? No. You guys don't have tonight, it's too young. How many of you wore a seatbelt when you were driving? Good. Now, I usually would ask the question, how many of you know someone who's been injured in a car accident? But I won't ask this here because you all know someone, because that's your patients. So if we look at the statistics, and these are WHO statistics, on a yearly basis, all over the world, there's 4.4 million people that die as a result of injuries. Now, 25% of those injuries are related to road traffic accidents. So either you're driving in a car or you're collateral damage from a bicycle, a pedestrian, or whatever. Others are electrocution, industrial accidents, drownings, conflicts, suicide, etc. That's 32% more than the big 3 communicable diseases. And you know how much money those 3 communicable diseases get in terms of funding. I'm not going to debate, and I'm not trying to say that those 3 communicable diseases are not important. They are. But I'm just saying that injuries is forgotten because everyone says that injuries, it's your fault. It's your fault that you're driving drunk or drunk. It's your fault that you're getting 300 people in a bus and traveling. And injuries do not cross borders. One of the big things about AIDS and HIV, way back, is that AIDS and HIV, these communicable diseases, they cross borders. So a lot of money was poured into this. But it's not the deaths that are important for us, for you as trauma and orthopedic surgeons, or anyone that's involved in caring for the injury. What's important is the disability, the people that survive. If you die, you die. You can't do anything. You don't get a chance to practice the skills that you learn in your residency program. The estimation is that for every death, there's about 10 to 15 people that remain with some type of disability. And out of those disabilities, about 75% of them are related to your everyday business. So that's a potential worldwide of over 34 million people. And you can say that that's 34 million people in LMICs, because 90% of this occurs in low and middle-income countries. Let's talk about a few trends that I've seen over the last few years. Some of you may know about ESOT, National Surgical Obstetrics and Anesthesia Programs, and the Surgical Obstetrics and Anesthesia Workforce. The WHO said that you need to hit 20 of these types of surgeons and anesthesia people per 100,000 population. You heard this morning that Baruch says that there's about 120 to 140 million people in this country. And if you look at the color of Ethiopia, it's beige or white. So you're under one. You're a long ways away, but you're not the only one. So but you've come a long way. You know, I remember 15, 10 years ago, there were only 2 residency programs in this country. Now I think there's 10 and about to be 11. So with COSEXA and with ESOT, you've been able to grow the number of trauma and orthopedic surgeons in this country, and as well as in LMICs. Now, the priority diagnosis, a lot has gone into about feet, about 10, 15 years ago. And injuries was there, but it was just creeping up. And Dr. Zerkel and Simon were developing their programs in a lot of the LMIC countries. Now, in 2020, injuries is making a little bit of a comeback and becoming more and more important. But you're still seeing French-related infections, pediatric infections that are quite important. In the future, you're going to see tumors, okay? Especially the osteosarcomas. And we've been traveling, we saw a case yesterday, and then I see some other cases where there's a demand for cancer treatment, for bone-related tumors. Your population is aging, but your population is still young. But there's a need for orthoplasty. Sports medicine is also very, very important because your population are getting more and more active. So those are the trends that we're seeing. Now, the training. 10, 15 years ago, there was some COSEXA training. Now the West African College of Surgeons has a trauma and orthopedic faculty, as well as the Ghana College of Physicians and Surgeons is also a trauma and orthopedic faculty. So you're seeing a lot more people getting involved in training trauma and orthopedic surgeons. You guys and gals here in Ethiopia have a unified curriculum. And as I said, you've got 10 residency programs. So we're seeing a lot more of you to take care, unfortunately, of a growing population. The population in Africa is really the only one that is significantly growing. All of the other populations in Asia, North America, South America, as well as Europe, are decreasing. Down to 1.5 children per women of weight of childbearing age. It's not about the money, but it is about the money. Okay? So if you look at the country where I'm from Canada, from a very, very small town in Quebec. And Quebec has socialized medicine, so there's no room for private. We pay 15% income tax, but we have quote-unquote free health care. It's paid for our income tax. And on the average, the government spends about $4,500 per patient per year on providing health care. Some need more, some need less. If you look like a crazy country like the United States, in the country I live in right now, Switzerland, where the Swiss are hypochondriacs, and the United States is medical legal driven with many, many things, they're spending close to $10,000 per patient per annum on health care. It's not just trauma care, but health care. So, if we look at some of the Anglo-Saxon countries, well, you're not hitting the mark, and Ethiopia is not hitting the $80 that is currently recommended by the WHO to make an impact. Other numbers to consider is the percentage of the GDP. Now, if the GDP is very low, 5 to 10% of the GDP is not going to hit the mark. But you, as a professional society, and as trauma and orthopedic surgeons, need to advocate to get a bigger piece of the pie, a bigger piece of the pie. Okay? Or else it's not going to go anywhere. It's just going to be trending in still water. Airlines in Ethiopia. Well, lots of good things. Slide from 2015, much younger Dr. Harrison. Dr. Ephraim was still, I think, a senior resident or fourth year resident at the time. Hugh is in the front row. And this is what we call the needs assessment that we did way back then. You see Dr. Grant Forward is there as well. So we locked a whole bunch of people up in a room for about 2 days. And over the course of 2 days, came up with some areas of intervention where we thought we could make a difference in trauma orthopedics in Ethiopia. And those were the areas that we looked at. We looked at education, local capacity building, reverse fellowships. And those of you that have worked with ADCA, we're pretty big on infrastructure. So we do infrastructure quite well. This is a picture of the ADCA patron that you all know him. He's a legend in this country. And he's attended one of the courses. I think that picture was from 2017, if I remember. So we set off on the first country initiative. And in 2015, 2016, it was Addis Ababa Center. So we set up with the Australian Doctors for Africa to educate all first-year residents with the pre-basic course. And that's a picture of the 2016 class, where it was still taking place at the Black Lion Hospital. And then the regional reference centers came up. So we traveled to Kawar, Oceana, Bahirdar, Gondar. I've been to all those places. I've visited all those places. And with the partners who signed with ESOT and with the Australian Doctors for Africa, I think, not me, but you have been able to develop something that works in your environment. And you see all the partners there. It's not an exhaustive list, okay? I ran out of room. Over the last 10 years, I've been fortunate to meet some very, very dedicated and good people that I can honestly call my friends, okay? I put the two big bosses on the top left-hand side, and these are all people that I think have contributed significantly to making what trauma and orthopedics are in this country right now. Along came BOSAD, bone setting against disability. Big problem with traditional bone setting, not only in this country, but other countries in sub-Saharan Africa. Many of the OWASA team said, we got to take a STIG approach. So they created a database of collecting all of the cases that came to referral institutions that were associated and had a complication related to bone setting treatment. And unfortunately, a lot of the children are affected. Children can't choose who they go see for health care. Okay? It's grandparents, parents, a lot of cultural pressures, and many of them with very simple injuries end up into traditional bone settings and with significant complications. this is at the start. I mean, it's very, very sad, and the unfortunate thing is I keep getting X-rays and pictures of kids like this on a weekly basis. And I think BOZAD is trying to make an impact now. BOZAD has taken the shift from being the sick approach now to being more of a care approach. Some educational material has been developed on preventing childhood injuries. Talks have been going on with the Ethiopian Public Health Association. They've approached the Federal Ministry of Health and Records to try to see about, I think eventually you'll have to regulate traditional bone setters, but that is going to be extremely difficult in a country that, first of all, you don't know how many they are. They're in rural areas. And last but not least, there are some videos that will be produced probably this year. So a lot has been achieved with BOZAD, but as they say, are we there yet? No, we're not there yet. We've got a lot of work to do. We managed to convince our donors to fund the second round of the country this year. So it started in 2023. And it will last 4 years, or until the end of 2026. I put the regional reference centers, and I'm going to put a big question mark. The conflict and the war has put a dent in what we are able to do and able to help out. So that's why the question mark is there. There's been a big priority identified in subspecialization, and we're still trying to figure out how to facilitate that. The paperwork to do this type of training outside of the country is becoming problematic. And I think the solution is going to be to develop more national fellowships, to try to convince the Federal Ministry of Health that you don't need 2 years, that you need 1 year is good enough. Okay? Some of the infrastructure development will continue. I think ESOT is well on its way to become a true professional association. The support of your members. Don't forget to pay your dues, quite important, because they can't survive without your dues. And last but not least, I'd love to develop a national Ethiopian trauma and injury plan, working with the government to have an integrated approach of how people that get injured can be walked through the system and get the appropriate care that they deserve at the right time. The other thing that was developed here about a year ago is standards of care. Now, you all know the United States, the UK, have tried to put in some protocols for the most common diagnoses. And one of them is hip fractures. It became a big problem. When I was a board trained a long time ago, I was talking to Jim. I graduated from medical school 40 years ago, and I've been an orthopedic surgeon since 1990. But I haven't practiced in the last 20 years. Whenever a patient, little old lady, came in with a hip fracture, we tried to get her done in the middle of the night because we didn't have any operative time the next day. There was no multidisciplinary team to take care of this patient. As a junior orthopedic resident, we were managing all the medical complications, diabetes, the renal failures, the dementia, and everything else. And that was not right. So people kind of figured out that this is a big problem, and we needed to standardize patient pathways. We needed to have a standard, acceptable delay for these patients. We needed to have a team take care of some of the medical issues where the orthopedic residents were not good at taking this, to try to optimize patient outcomes. And one of those patient outcomes is the 3-day mortality. With these particular protocols, standards of care guidelines, at least in the UK, where they have a database to be able to do this, and this is where fracture care registries, trauma registries are extremely important, they were able to decrease the 30-day mortality rate by 40%. Now that's a real number. And now they have these auditable standards of care that people should adhere to. We tried to do the same thing. We started with the census countries. We selected one trauma and orthopedic surgeon who was a leader in that particular country. We invited members from ESOT. We also invited members from WACS and also from Ghana. We locked everyone in a room for 3 days. We told them about what were the more common diagnoses that were problematic in this country. So we took a lot of shortcuts because normally it takes about 3 to 6 months to develop these. We did this in 2 days. This is the map and the representation of people that were there. I think Ephraim and Maggie were part of the group. Baruch also came by and said hi. And at the end of the day, we chose 3 topics: closed femoral shaft fractures, closed ankle fractures, and last but not least, open tibia shaft fractures, all grades, 1, 2s, and 3s. If you turn to page 36 of your book, of the ESOT book, the guidelines are there. If you turn to page 35, I think you'll see a picture of me from 1996 at the bottom right-hand side. But they're in the book, and they were also distributed in laminated forms. We want you to read them. They've been adapted to Illinois environments. We give you enough latitude to adapt, but we want you to put them in the operating room, in your areas of environment. And we would love for you to adopt them. Bring them to the surgical meetings, surgical councils as well in your hospital. And just some of the few quotes of these honorable steps, they all fit on 1 page. You know, orthopedic surgeons remember 3 things, and they can read 1 page. So the closed femoral shaft fracture it needs to be fixed with an intraabdominal locking nail within 5 days of presentation to the referral institution. It doesn't say what kind of a nail, but we hope you'll choose a sign nail. It doesn't say whether it's closed or open, but it's getting a little harder to do them closed, so we might have to open them. And it doesn't give, it says from the time the patient hits your door, because you don't control a lot of the time, it's the time the patient reaches your hospital. For closed ankle fractures, it's pretty simple. If it's one of these fractures that has a good chance of being stable and is anatomically reduced, yes. But you need to follow it, because if it becomes unstable, well, open reduction is augmentation. But it doesn't tell you how to do it, because that's your prerogative. The open tibia shaft fractures took into consideration these 3 B's that a lot of you see, which says that you should not do a primary amputation unless there's been a consultation with 2 senior surgeons. They agree. And you also write something in the medical records to say that 2 surgeons agreed to do a primary amputation, and make sure that you're informing the patient as well. Yesterday, when we were making rounds in Jiga, there was a patient that had a conflict wound around his elbow that wiped out his arteries, and he couldn't come to the fact that he needed an amputation. So right now they've got an external fixator on until the patient can finally decide to have an amputation. But it's culturally very, very difficult, I understand. In there is the WHO surgery checklist that's included. There's some modalities about physical therapy, there's a weight-bearing status, and last but not least, there's DVT prophylaxis recommendations. Real simple. It's not rocket science. And it came about as a consensus. I think the future of improving care for your patients is these protocols. It's not these protocols, these guidelines. They're not protocols. They are guidelines. Some of them are aspirational. And next month here in Addis, not at this hotel, we'll be tackling the next 3 diagnoses. Hopefully we'll get one of the pediatric diagnoses in these clinical guidelines. So, the news in the dump. Still a long time. The news is visit frequently. Go back. You do not do business on the internet. All right? We want us to wise to the eye. And this is why Jim and I do these unanswered about scouting trips. Initially they were scouting trips, but now they're really scoping trips, where you see what's going on, and this is not just spying. This is really to figure out what's going on the ground. Okay? We have to be culturally sensitive, and we do have an ethical duty to first do no harm. You know, this is, it's actually not in a Hippocratic oath. You really read the Hippocratic oath closely. The further y'all think it is, but it's not. But we have an ethical obligation to first do no harm. The don'ts, well, judge. You look at the picture on the slide, it looks like a really messy plastic. It is this, but it's functional. Everything is there. There's plastic, there's a cast stop, there are cast sparrows. And it could do with a little bit of cleaning up, a little bit of organization. But everything there is there, and it works in that environment. I still think that it's not our job, it's AOI's job, to pay or provide what the government should be providing. And that's the basic basket of goods that you need to treat your patients. And we need a small fragment set, we need a large fragment set. I think we're very fortunate that Blue and G and the Spine Fracture Care International, Bruce is so successful with his nail, but somehow the government has to throw in the cost of the patients. I think the patients have to contribute. Surgical safaris, where surgeons from high-income countries come in, operate and leave behind complications. It has to be coordinated. I'm not saying that I'm against high-income surgeons coming to help out, but they should be holding the knife. Okay? Local people should be holding the knife. So, I take home messages. Musculoskeletal injuries are a big, big problem, not just in your country, but in a lot of sub-Saharan countries. We're active in about 26, 27, 28 of them. Not as much as Ethiopia. Ethiopia is a favorite child of ours, along with 5 other countries. But as you saw in the first part of the presentation about the injuries, it's a big problem. But people don't know about it. Or if they do know about it, they've got other issues with mother-child, C-sections, cardiovascular disease, diabetes, cancer, and the communicable diseases. There's 3 categories of diseases. There's the communicable diseases or infectious diseases. There's the non-communicable diseases, so things like diabetes, hypertension, cardiac disease, renal disease, cancers. Injuries used to live in the non-communicable diseases, but now they've tried to take it out. I'm not sure if that's true or bad, but it stands as a standalone category. It's not the deaths that are associated with the injuries, it's the disability. And as you saw, it's 10 to 50 for every patient that lives. And that's a significant number of patients where you can really make a difference. And you saw that as most of the disabilities, 75% of them affect the extremities and musculoskeletal. But it's about you taking care of your own problems. It's about us as international organizations to help you sort out this problem. So, back to my story. The child was lucky. As a surgeon, the child ended up with a well-trained trauma and orthopedic surgeon. Not a pediatric orthopedic surgeon, but a well-trained trauma and orthopedic surgeon who knew what to do. And you got a perfect looking X-ray with all of the anatomical lines is fine. Thank you very much for your attention, and I hope that the rest of the meeting was worthwhile. Thank you.
Thank you so much, Dr. Cloud. I think it's really an eye-opening talk, really. And we know more than anybody, right? We have a poor population that completely depend on mobility to support themselves and their family. So Dali's disability adjusted life years is quite very high for trauma and injuries. So it's very important to make sure our young working population stays healthy and recovers back to being productive. Thank you so much again, Dr. Claude, as always. And the next presenter, Dr. Narendra is a managing director for the Brand Group of Hospitals in Pune, India. He is quite famous for his contribution to replacement surgeries. He's done over 6,000 robotic total knee replacements so far, and he has contributed not just to replacement surgery, but spine trauma in his setting. So let's give him a round of applause and welcome him to the stage.
Good morning, friends. Greetings from India. It is my fourth or fifth time to visit in Ethiopia. I was here about maybe 10 years back for your ESOT meeting, where I had given a talk on trauma care. That time I used to do a lot of accident care, and basically it was a golden hour presentation, the workforce out management. And in some difficult situations, we have to, instead of golden hour, like in your country, when the patient travels from there, it was a silver day concept which I had there. And it was a pre-hospital trauma care, which was the topic that time. Thank you. I am extremely thankful to Dr. Akram and Dr. Biru for having me here. And can we see the slide? Okay, great. Applause for Shreya and all the software team. So, greetings from India again, and this is my beautiful city of Pune. It is just south of Mumbai, about 100 kilometers south of Mumbai, Bombay. And it's a historic city. It was the cultural capital of state of Maharashtra, which is the second largest state in India, and very highly populated, as you all know. My city's population is huge and is probably 3 times of Paris. So, and it's a very well-known, it is called as the Oxford of East, and we have a lot of institutes where we have a lot of Ethiopian students also who are studying in Pune, and we have all types of engineering, medicine colleges. We have 5 medical schools in the city. So it's a very advanced thing, and from KG to PG, as we call it, you have a lot of institutes including. These are my hospitals. I started practicing orthopedics in 1993. graduated from Disability College, went to US and Sweden and other countries, got my education done in trauma, spine, as well as joint replacement surgery. And now, principally, I am now looking after joint replacement. We have orthopedic focused hospital. This is a teaching institute for postgraduates as well as a lot of domestic and overseas fellowships. So I'll be giving numbers to you all where any interested person can apply for fellowship. Of course, my brother Dr. Birut is here and he will help you to reach us. These are my disclosures. So now going to the topic, total knee replacement now over last 4 decades has been 4 or 5 decades has been an extremely successful procedure, and it is practiced widely now. When I was started practicing, it was very rare in India also, but now it is a very high volume. We are doing it, and I'm sure that in coming years, a lot of patients will come to you for the replacement surgeries in Ethiopia. Even if today's number may be less, but it is going to increase day by day, and there are a lot of advances. And it's really a life-changing surgery, and it is very successful. Arthroplasty has not remained, only totally replacement. We have now patellofemoral replacement, we have partial replacements of medial or lateral compartments, we have huge 2-compartment replacements, or we have totally replacement. So all these surgeries are being done. But even if saying so, still about 20% patients are not extremely happy. They may be painless, they may be walking well, but still when it comes to happiness, they say that no, I'm not happy. So there are certain reasons for that, and that I'm going to cover, and why technology is important, that I'm going to cover in today's lecture. So when we say advances in arthroplasty, there are 3 T's, what I say. The tools, what we do, say in 80s or 90s, whatever instrumentations what we were getting were not exactly precise. They were, very good instrumentation, lot of instrument trays. That has improved over the last 2-3 decades, and we are getting good designs. We are getting good implants. We are getting good materials. Even now in your city also, in your country also, there are various distributors, same distributors which are giving us this Merrill and all those people. They are supplying high volumes in India. Even I am using their implants. Techniques have evolved, minimally invasive surgeries, the CRs, the extensive protocol which I developed, the unicompartmental technology, navigation, online, robotics, they are all playing their role. So basically they are all contributing to the improvement in outcome. When we say outcome improvement, that there are 2 variables, 2 factors which are primarily important apart from surgical skill, that is the accuracy of implantation and implant design. Implant design has very less impact on the ultimate outcome, what it is, and the manufacturing processes, materials. We have various materials also, but implant accuracy is the most important determinant for patient outcome. So we have various designs like the PS design, which is commonly used, the cruciate retaining designs are there. We have rotating platforms there. We have this journey PCS design there. There is a differential cut of the femoral condyles, and so you have oblique joint like a natural knee joint, which is in 2 to 3 degrees of ours. So you get all these kind of designs which are available, and I'm sure as the numbers in your country also go on increasing, you will be having access to all these newer implants. Then you have partial replacement, bicruciate retaining implants. So there are various implants which are at the disposal of us. Unfortunately, in India, due to the high volume what we are doing now, all the designs, whatever available in the Western world, they are all available with us. There are various materials also. We are all using cobalt, chromium, titanium implants, but now you get this so-called gold implant, which is also, I think, available in Ethiopia also now. Mary has that implant. It's a titanium ethiopian nitride coated implant, which is a non-allergic implant. It doesn't even in metal allergy patients you can use it. Recently, we did a ceramic total knee replacement in India. It was the first in India in my hospital. We did this ceramic knee. We have oxygen, which is the coated implant again from Smith & Nephew. So you get all these types of implants. So this is just a video showing implantation of this gold implant. So you have this coating here. Even the back side also has coating. It has pockets for cement fixation. It has got studs also. And this is a TPL component, which is a fixed bearing design. You've got key, which is actually a rough finish, which can have very nice gold in the gold. So these are advanced implants, what I think will be available with your surgeons also very soon. It must be already made available by the concerned company. And then you fix it. Now come to the basic thing, that accuracy formulation. Ideally, mechanical access is very important. Unless we reconstruct the mechanical access, the patient is not going to get deformity correction. Neither the patient is going to get completely painless. And thirdly, there is going to be unreasonable wear of the body implant. And that's why your mechanical access has to be completely, absolutely perfect. Accuracy of implantation depends on lot many factors, like the patient's anatomy. Sometimes in such patients, the accuracy of implantation may be very difficult, like shown in that photograph. Soft tissue releases balancing, it is completely surgeon dependent in the traditional or conventional knee replacement. So these are all going to ultimately affect the accuracy of implantation. There are many variables in the femoral side, the center of femoral head, the flexion extension of the femoral component, distal femoral cuts, rotation of the femoral component, varus and valgus alignment of the femoral component. So any state of any of these variables will go wrong, there are chances that our ultimate access of mechanical access is not going to be achieved. There is a study which is published in the Journal of Arthroplasty that if you err by 1 millimeter of entry point, then there will be 2 degrees of deformity. And that's a narrow margin where a conventional knee replacement is being done. Hardly 1 millimeter will give you 2 degrees of deformity. So if you have that 1 degree on femur, 1 degree on tibia, the combined deformity can be very huge, which will be which is called as the outlier. On tibia, these are the variables like resection level. Sometimes you can increase, take more bone. If you take less bone out from the tibial cut, that knee will be tight. There is flexion deformity. Valgus alignment may go wrong. So there are a lot many variables, and that's why there will be ultimate outcome will not be optimal. There are no cutting errors. We use the saw. The saw can stripe off the sclerotic bone. It can go in the osteoporotic bone. And so there may be, again, even if your jig placement was perfect, your cut ultimately will be actually having a deviation from your normal, whatever desired cut would have been. And there are a lot many instrumentations. Any one instrument to go wrong, then you are going to have outlier. This interesting study in orthopedic proceeding journal, you see that even in high volume cases, experienced surgeon, the outliers. Outlier means that whatever alignment you wanted to have, there is a deviation from that alignment by more than 3 degrees. So 30% that every one case after your 4 cases is going to go wrong. So that is the sort of statistics why there was a need to develop technology in the field of arthroplasty. And if you get it wrong, then it's a disaster. Patients will have a lot of problems. Revision surgeries are difficult. They are time consuming. They are very costly. And so ultimately, our aim, if you are offering a surgery of knee replacement, it has to be better, be absolutely perfect. Another thing is that TCAR is not about just cutting bone. It is a soft tissue surgery. So we tell our resident fellows that do an adequate soft tissue surgery. So what is this adequate? Adequate may be different for doctor, it may be different for me. So it is all very subjective. So there was a need felt by arthroplasty surgeon that some objective tool has to be there. So we have to take help of science. Surgical techniques has to improve. We have to, there are different concepts of balancing the knee, like the mechanical alignment, kinematic alignment, concepts of changing. Everybody's knee is different. So there is a classification called as CPAC classification. And it has divided classified the knee joints, normal knee joints into 9 phenotypes. CPAC 1 to CPAC 9. And everybody's knee joint is different. And we all used to in previous conventional technique, put the joint in exactly the same way for each and every patient, irrespective of their phenotypes. So if a person had oblique joint line, we were giving him a straight joint line, a completely horizontal joint line. And that's why the unsatisfied patients of 20% unsatisfied rate was there. So now, about 2 decades back, computer-assisted navigation was started. It was the first step towards technology. So it is a navigation which will help the surgeon to get your alignments right on the operation table. But it has certain drawbacks. Navigation is like a diagnostic tool. It stands in your operation table, tells the surgeon that this is the level of cutting or this is the release what you are doing. You can measure it, but ultimately surgeon has to fall back to his skill and then again implement the surgery with the traditional way. So again, the errors were not reduced to a great extent, even if you have a navigation system. So then, what if you have a system which helps us in getting the alignment in all three planes? It gives a dynamic, alignment balancing. That means the knee is balanced throughout the range of movement, not like only 90 degrees and extension. It is completely balanced in all three planes, all over the range of movement. It allows objective analysis of ligaments, like there is a number which comes in this, and that is where robotic surgery comes in picture. So what is a robot? Robot is a machine, especially one programmable by computer, capable of carrying out complex series of actions automatically. So now here the robot will help us in getting the deformity analysis also. Number two is that you can actually do a virtually do the surgery on the computer before you actually start cutting. And then lastly, you can then implement your plan with a robotic handpiece or robotic tools. So this is the advantage of robot. So I'm going to show some videos of different robotic systems. Incidentally, we have all the robotic systems at Lokmanya Hospital in Pune, and my fellows are trained on all the robotic systems. So it can be humanoid, which is not surgical robot, and surgical robots are non-humanoid robots. So it's a long history, and currently, you have robots which are active, which can be passive or semi-active. Semi-active robots are the ones which are very commonly used all over the globe, and this is where the surgeon is always cutting from on. Active robot means surgeon plans and clearly stands out, and the robot will carry out all the bone cutting. So these are some systems in the market which are active systems. Personally, I am not very much aligned to that. I need to be involved in the surgery entire time. My feel, my hand feel, and judgment are very important. I cannot give the surgery to robot. So I don't encourage the active robotic system. I always use all the systems like all these semi-active or semi-automated systems are used. And the market is going to be flooded with robotic systems in the coming decade. You see 159 robots are pending every approval, and these robots are being developed. So all of us, and ultimately once there is a competition, more and more numbers are being used, the cost also is going to go down. So we have to get trained and we have to look at the future, and I urge that some of you who are interested, come to our center, learn about robotics. It may not be immediately available, but I don't see that it will take a lot of time to get technology in your country. So this is how it works. Now, first is the mapping. Now here, to understand the bone, we just move the probe over the bone, and it creates a virtual three-dimensional image of the bone on the computer. So there is nothing left to imagination. It will create the exact bone model on the computer, and that will show that what is the anatomy, what is the morphology of that particular knee joint, what we are practicing. So I'm just doing this on the display into the femur, and you can see a nice virtual model being created by the robot. So this is the first step in robotic surgery. It is called as mapping. So you rotate it wherever you are mapping, that surface will get automatically rotated, and you will have a beautiful model which is there in test. So this will analyze the deformities, this will analyze the size of the implant, this will analyze the rotation, all whatever variables in TR, whatever I mentioned in some earlier slide, everything is told to us by this mapping of the bone. This is a fantastic technology, and the same thing is done on the TR side, and you have mapping of the TR also. So once demo is done, you can see that you can now, that blue line which is there, that is, it's slightly faint there, but the blue transverse axis is the transepicondylar axis. So epicondyles are a region. When we did a traditional knee replacement, that would go wrong. And that is where here it is giving us exact the points, epicondyles, that is being mapped. And the same thing is done on the tibial side. We will just move the probe on the top of the tibia and the tibial condyles, and you will get actual exact morphology of the bone. So any child also can do it. So it doesn't, it gives you consistent, reproducible results. It is not depending on whether, what is the mood of the surgeon, whether he was happy, whether he was tired, nothing. It will get absolutely, whether the surgeon was junior or senior, it uniformly gives the same results and takes out all the variables from the surgery. So this is called as mapping. So this is done in different ways in different robotic systems. So now I look at what robotic systems are available. So this is the first generation robot Mako from Stryker. It was the first generation robot where a CT scan was required of the entire limb. Now the recent, these were image-based robotic systems, and they were very bulky. They used to take a huge space in the operation theater, so you had to get accustomed to that arrangement in the operation theater. So there were a lot of downsides to that. This almost about more than a decade and a half, this Mako is there in the surgical market. Second generation robotics is what I showed just now. That was, image free. So you don't require a CT scan for that. It is done with a handheld robotic system. It is very convenient. You don't have to. Doesn't occupy any space in the operation theater, and you just do carving. We call it sculpting. So you don't have to use a saw also in this. The burr is there. That burr will take off the necessary bone, and it will just cut the bone. So this is a handpiece which will give to the surgery. It's like arthro sword. So it's very convenient. Then we have this another system which is third generation, that is ROSA system from Zimmer, where it actually doesn't use any cutting instrument. It will keep the jigs and it will move the intelligent arm which will place on the jig placement principle. And the fourth generation varies from Johnson & Johnson, where you have a table-mounted robotic arm which will be carrying out various difficult tasks in the surgery. And Ecubus is a completely automated robot from Mail. So there are, advantages of robotics, that it is a three-dimensional assessment of deformity. It gives you whatever alignment philosophy you believe in, you can get it. Completely, all the cuts are done by the robotics, all the variables are taken care of. So all these drawbacks are taken off. So there are various stages. It will give perfect mapping, like I showed in one slide. It will give you exact real-time imaging. It will help us in getting precise planning and a perfect execution. And surgeon can actually do a complete mental walkthrough before the procedure and do the total replacement. So you can use the robots for the most complex cases like the partial replacement. It is a very great surgery, but it is very hard to get every time accuracy. So partial replacement also now the numbers are going on increasing, and actually patients can do all lots of activities. You preserve the ACL, you preserve the PCL. Don't have to release the medial collateral. So UK is a very great surgery, but it is very hard to get the accuracy. So robot brings extreme accuracy in this, almost 100% accuracy. So all these variables are tackled by the robotics. So this is a small video for UK, that is unique compartment. You take a small incision, carefully dissect the skin flaps. Then take a parapatular or medial-vascular approach and expose the medial condyle. In this case, because the medial unique compartmental osteotomy, you can see on the femur, the ulcer on the femoral condyle. You can see the osteophytes. Fortunately, the lateral compartment was absolutely normal, so you don't have to do a total replacement. Then you put this, what is called as the tracker pins. So on the femur, 2 pins go, and these round are the sensors. Then you take the knee to the range of movement so that the computer understands what are the ligament structures. Then give a stress range of movement with the CD tracker and the medial condyle. And then do the mapping of that particular condyle which is going to be replaced. So again, just move the probe on this, and this creates a real-time three-dimensional virtual image of the femoral condyle, and same thing about the tibial condyle also. You can adjust the rotation of the component, you can adjust the slope, so all the variables can be adjusted by a single instrument, single intelligent instrument. You don't require any trace of instrumentation. One instrument, that is a robotic arm, that is enough to carry out all the complex steps in the surgery. Once this is done, you get this. So you align the implant, you can see the gray is the implant, yellow is what is our plan, and you can move the implant to whatever direction you want, whatever alignment. So I am taking the tibia forward, adjusting the slope, exactly the joint line is restored to normal. So nothing left to imagination. Completely, it is a perfect surgery every time we do it, and then you know the axis of movement also. Then you can distalize or proximalize the femur. You know where is the point of contact. That is dots are point of contact. So again reconfirm that your trackers are not moved, and then you cut this bone with a burr. So you get this virtual image where red is 3 millimeters, blue is 2 millimeters, green is 1 millimeter, and with the burr you just carve out or sculpture the bone. You don't have to use saw. You don't have to use any other instrument. Only one burring instrument is enough. Make holes for the implant in the studs. After that, we go to the tibia. I do this tunneling technique. It takes hardly 2 minutes for femur and 2 minutes for tibia. Average time taken for surgery for total replacement has gone down with robotics now. Initially, it is the learning phase, but once you learn and adapt to the skills, the surgery is done hardly in 17 or 18 minutes. I have published a paper on that operative time. Then you take a trial, see the movements, again you get a chance. If it is not optimum, you can again go back, change the planning, and again use on burring or sculpting. And then cement the components and put it in place. So in this particular case, we are using the oxynium implant, that is oxidized zirconium, which has got a very good wear properties. It has got almost 30 years in survivorship data. And you can see the time of surgery goes down to almost 16, 18 minutes now. And every time it is a consistent preparation, you don't have any variables, and you get consistency in implantation. So any number of cases you do, every time the X-ray is going to look alike. So there are, now we have completed recently 16,000 robotic surgeries in the last 7 years, and that is one of the highest in the world. So you can see that UK is going to increase, and there are certain publications which is saying that robotic surgery is going to be the way forward for the cancer replacement. So now I'm going to show you the total knee replacement videos, where again you will go through all the steps. Where initially it is it's mapping. Mapping is done like we saw in earlier video. Every time it is the same consistent sort of a workflow, which is helping surgeon to understand the deformity, understand the bone defects to perfection. Once we do this mapping on the keyboard side, we go on the tibial side and then analyze the overall deformity. I will just fast forward this. Then the TBI is mapped. After mapping, you get all this virtual, bone people with the bird. You just start out this, so you can see the bird in action. So just take out some millimeters of bone. So it's very precise. There is no bone loss. There is very hardly any ligament release is required. So it becomes a very objective surgery and very precise surgery. So just budding of the bone is done, and that takes care of the complete shaping. Now this is a